Hello, everyone. Welcome to Global Medical Education CPD webinar series. Welcome all. I would like to welcome our speakers and thank you all for joining. My name is Dr. Naseem Naqvi. I'm a consultant physician in the NHS, and I have with me Dr. Mansoor Ali, who is the program coordinator, and I will ask Mansoor to introduce our speakers today. Thank you.
Thank you very much. Thanks, Naseem. Thank you for the program. Thank you to speakers today. So good afternoon, good evening, good morning, wherever you are. It's my pleasure to invite Sadaf Fatima Jaffer Boy, who's a consultant oncoplastic breast surgeon from University Hospital of North Midlands, also a clinical tutor at the Keele Medical University. So Sadaf, it's so nice to come. Actually, happy you're back again. This is probably your third presentation in the last 4 or 5 years since we started our webinar. So the platform's all yours. Please go ahead and I'm looking forward to come back hearing your presentation. Thank you very much. Thank you.
Thank you, Mansoor.
Thank you, Mansoor, and thank you, Naseem, for inviting me again and giving me the opportunity to present at your forum. When you asked me to present on breast lumps, and I thought, well, where should I start? And I decided to talk about breast lumps in general, and I'll talk a bit about breast cysts, talk about some benign lumps, and then move on to cancer. So just to refresh our minds, what gets referred to the breast clinic? As per the NICE guidelines, any lady who's got an unexplained breast lump above the age of 30 gets referred. There are, of course, other criteria, including nipple changes, such as nipple retraction or nipple discharge, and other changes that could be of concern to the primary care physician. There are also criteria for ladies who are under the age of 30. So someone who's got unexplained breast lump, the primary care physician may decide to send these patients as a non-urgent referral to the breast clinic. So we do often get questioned, why is it necessary that these patients need to be seen in the breast clinic, and why can you not see them just on the ward and examine them, especially if there's an inpatient? So just to give you a bit of a flavor, what happens in the breast clinic, we do a triple assessment. For those of you who are planning to sit any exams, that is your keyword. Use the word triple assessment. That is almost always done all the time in breast clinic. During the triple assessment, we take a history and clinical examination, do breast imaging, whatever is necessary, and perform any biopsies, again, if it is indicated. So what are the risk factors that we ask for? Just to remind ourselves, there are certain risk factors which are particularly related to breast cancer, such as early menarche, late menopause, nulliparity, or having a late pregnancy, i.e. first pregnancy after the age of 30, not breastfeeding, use of exogenous hormones such as contraceptive pills or HRT, family history, very important, of breast or ovarian cancer, and previous abnormal biopsies. So having abnormal biopsies, I wouldn't go too much into the detail of this, but things like lobular carcinoma in situ or atypical hyperplasia, those are the kind of things that we do ask when we talk about previous biopsy results. So what do we do in terms of clinical examination? Of course, I won't go into the details of it, but if you do find a clinical abnormality, we do look at the size, etc. And based on overall clinical assessment, we grade our clinical findings as anything between P1 to P5, which is perhaps self-explanatory, P1 being completely normal, P5 being malignant, anything in between could be benign to indeterminate to suspicious. So everyone who comes to breast clinic does not require imaging, and this is something that all physicians need to know about it, whether they are in the primary care or in the secondary care. For ladies who are above the age of 40, if they do not have any clinical findings, we still do a bilateral mammograms. But for those who are under the age of 40, if there are no suspicious findings, we don't do any investigations. If there is a clinical abnormality for those under the age of 40, we start with an ultrasound scan and then proceed to a mammogram if that's deemed necessary. And the mammograms are only done if the radiological findings are suspicious or indeterminate. An ultrasound scan of the axilla is done where either on ultrasound or mammogram, the radiologists feel that this lump could be malignant or an indeterminate or a P3 lump. So once the lady has had all the breast imaging, including a mammogram and an ultrasound of the breast plus minus axilla, we then move on to histology. So histology, the gold standard for breast histology is a true cut biopsy, which should be done under image guidance. Either that is mammographic or ultrasound, depending on what modality can you see the abnormality. In most of the units, if there is an abnormal lymph node, the axilla is biopsied with a true cut biopsy. But supposedly, if the lymph node is quite close to the vessel, sometimes the radiologist may do an FNA. If we do find there is a clinical abnormality, which is very superficial, i.e. in the dermis or in the skin, then we do the punch biopsy. So all this is done in the breast one-stop clinic where the triple assessment is being carried out. So what are the kind of things that we do see in breast clinics? It varies from anything being in the skin to something within the breast tissue itself. And you can see something in the skin can be referred to as query breast lump, which may be as simple as a sebaceous cyst. Things like lipomas do get referred to breast surgeons. Then comes the problems within the breast parenchyma, such as the cyst, hematoma, hematomas, benign tumors like fibroadenomas, phalloides, or malignant like carcinomas or sarcomas. I'm very much mindful that some of you may not have seen mammograms, and this is just really to show you what normal mammograms look like. So mammograms, these are essentially x-rays of the breast. They're done in two views. Normally for any other part of the body, you would say an AP and a lateral view. For mammograms, we do a craniocaudal, which is the picture on the left, and a mediolateral oblique, which is a picture on the right. The way to differentiate is on the mediolateral oblique. If it is done properly, you can see the pec major muscle, which is right here. This is an absolutely normal mammogram. Two views are taken on each side. And then you come across these findings. As you can see, you can see an abnormality. There's a density around there, quite well defined. Looks quite smooth. And in these situations, you would think this is probably benign, but look at the size of it. It is quite a sizable lump. And although radiologically you think this is a benign one, the radiologist would still go ahead and biopsy it just to prove that this is a benign lump. The fact that this lady has had a mammogram at the outset tells me she's above the age of 40. So then comes with other breast lumps. This is another lady who came to the symptomatic clinic with a lump in the breast. You can see that's the nipple. You can see a density around there. You can see it on both MLO and CC view, and on ultrasound scan, quite well-defined echogenicity. And this was actually a cyst that was aspirated. And then the question comes is, why do we have to scan if we know clinically and radiologically this is a cyst? That is really to make sure you're not dealing with something like this. This is a lady who had a cyst. You can see it's quite similar to the previous image, but there is a solid mass within the cyst. And this in itself can be a sign of a carcinoma that sits within the cyst that we call, sometimes we can be an intracystic papillary carcinoma. So the reason we scan the cyst and we aspirate it under ultrasound guidance is really to make sure that there is nothing, there's no solid component within the cyst. What about clinically benign lumps? And you see a spectrum of changes from fibroadenomas. And you may all recall fibroadenomas. These are your breast masses, which are very benign feeling lumps, commonly seen in young women. And the national guidelines are anyone who has got a fibroadenoma on ultrasound scan, and if they are above the age of 25, they should have a biopsy. And the reason is here. Look at the two scans. Both of them very well-defined lesions. Both these ladies were in the 30s. The one on the left came back as a fibroadenoma. The one on the right came back as a triple negative cancer. So triple negative breast cancers are the most aggressive kind of breast cancers. And sometimes they can feel benign. They can look radiologically benign as well. So this was another interesting case that was sent to us from primary care physicians with query sebaceous cyst. Just to give you an idea, that's sort of the surface of the skin. It is not far from the skin. If anything, it's probably a millimeter or so. Because it was so close, no wonder that the primary care physician thought this was a sebaceous cyst. And see how irregular those margins are? When you do a mammogram, you see this is away from the skin. So that's the skin. This is the breast parenchyma. You can see it more clearly on this view. This was not actually a sebaceous cyst. This was a cancer, which was very close to the skin. But it wasn't an epidermal origin. It was primarily a breast cancer. So the next question comes is, do all benign lesions need intervention, even if they look benign on imaging? Like I said to you, cyst, we aspirate cyst if the lady comes to clinic and she's symptomatic with a breast lump. If it is an incidental finding and she's not symptomatic, there's no intervention required. For fibroadenomas, like I said to you, mainly for the same reason. If someone is above the age of 25, clinically and radiologically, this looks like and feels like a fibroadenoma, a biopsy is not indicated. Whereas if someone who's who's got radiological appearances of a fibroadenoma and the biopsy is concordant with that, we don't excise it. And this is dependent on the size criteria. So if it is less than 3 centimeters, we don't excise it. If it is more than 3 centimeters, even if it is a biopsy proven fibroadenoma, we do excise it to make sure there is no stromal component or a sarcomatous component to it. If the histology comes back as indeterminate, i.e. B3, we do offer excision really to rule out the phylloides. And you may recall phylloides are very different as compared to fibroadenomas. These are stromal cell lesions. They vary from their malignant potential in being extremely, totally benign to borderline to malignant. And the malignant phylloides are the ones that behave like a sarcomas. A bit about breast cancer. We know it is very common. 1 in 8 women in the UK develop breast cancer. It can be symptomatic or screen detected. In the NHS, the breast screening program is offered to ladies between the age of 50 to 70 years. The ladies are offered bilateral mammography every 3 years. For those ladies where they are at a moderate risk or high risk of developing breast cancers as compared to the general population, screening mammograms or MRI is done at an earlier age. But despite of all the advances in oncological treatment, surgery remains the mainstay of treatment. So malignant lesions, very different as compared to the benign lesions I showed you earlier. Look at these. These are spiculations. You can see those little tentacles coming out of the main lesion. The bit in the middle, which is sort of dense, bright white, that's a marker clip that gets inserted at the time of the biopsy. It's a standard practice to put a marker clip whenever a biopsy is done. So this is how a typical malignant lesion would look like with spiculations. Again, more examples, more denser tissue. You can see this is definitely a lump in the breast. And I hope you can all appreciate there are tiny little white dots within this lesion that we call as microcalcification. So some cancers are associated with microcalcification, which in itself can be an indicator of underlying DCIS with it. Unlike the previous mammograms, look at this lesion, quite very well-defined, quite smooth borders. This is a lady who's in her 60s. That's a nipple getting pulled in, and you can see the white calcifications around it. This did not have the spiculated appearances, but this was again a triple negative cancer, like I showed you earlier. So sometimes triple negative cancers can have a very well-defined kind of lesion rather than a spiculated appearance. It's all good when you can pick things up on mammography, but sometimes lesions are not seen on mammograms. Hence, it is very important that anyone who's got breast symptoms undergoes triple assessment. This is a lady who came to clinic with a lump in the breast. There's nothing obvious to see on those mammograms, but look at this MRI scan. That's the nipple. There is this cancer. You cannot appreciate at all where this cancer is. So on rare occasions, the numbers are very, very small where the cancers are mammographically occult. And sometimes cancers are not palpable, which is how most of the screen detected cancers get diagnosed. These are small cancers. That's the marker clip inserted at the time of the biopsy. This was an 8mm cancer that I've recently excised. It was completely impalpable lesion. So I'm sure you would have all seen these kind of scars somewhere during your clinical career. And if there are junior doctors on this forum, don't be alarmed when you see these kind of scars. Traditionally, that's how wide local excision or breast lumpectomies were done. And you could see an obvious distortion of the breast, indicating that this lady has had previous breast operations. But with modern surgery, things have changed. This is a lady who's had a cancer operation, very much like the lady, these pictures I've shown you before. She had a tumor somewhere around here, and another tumor was up in the upper central quadrant. The scar just goes around the areola, and you would not be able to tell where the actual cancer was. So if you see someone who's had scars like this in your clinical setting, be it on the ward or be it on outpatients or be it in primary care, always ask them. You cannot decipher just by looking at the scars why the surgery has happened. Again, a similar lady, all I can tell is that this lady has got asymmetry. See how the nipple is sitting higher up as compared to the one on the contralateral side. This is a scar that goes around the areola, similar to the lady on the left, and she's had a lumpectomy for cancer. Again, sometimes lumpectomies are done with a breast reduction or an uplift. So the scars will not tell you whether the reduction was mainly for cosmetic reasons or for breast cancer. So this lady had a cancer on the left and had a symmetrizing procedure, i.e. something to match with the contralateral side at the same time when she had her breast cancer operation. So this is what modern breast surgery is. You won't see scars which completely distort the breast, but you would see scars which almost look like as if the lady has had a reduction. Again, something similar. So this is a blue dye, don't get alarmed. The nipple is not abnormal. She had a lump in the upper outer quadrant, and what has happened is the lump has been taken away. And just to improve the cosmesis, she had the fat taken more towards from the back, and that's been flipped over into the breast, really to improve the cosmesis. But sometimes you may come across scars like this. This is a lady who's had a simple mastectomy. Look at the scar. So she decided against reconstruction, and all she wanted was a simple mastectomy. So you may see scars like this when you see them somewhere in your clinics or outpatients. But they do get options to have a breast reconstruction if they want to. So sometimes the scars with reconstruction can be hidden in the skin crease, like this lady. She's got a scar in the inframammary fold. You can't see it on this view. She had an implant some time ago. This time around, she wanted an implant. She had cancer on the right side, so she wanted a reconstruction. But this time around, we had to make a cut around the areola and the nipple. So that's why you can see the scar on the right, but you can't see the scar on the left. You may come across things like this, where someone has had an implant-based reconstruction. So this lady has lost her breast. She had a reconstruction with the implant, but she had to lose the nipple because of oncological reasons. And sometimes they have delayed reconstruction. So like I showed you, the other lady who had a simple mastectomy, a couple of years later, this lady came back and wanted a reconstruction. And this is a scar on the back, which is to harvest the latissimus dorsi muscle. And the muscle has been used to reconstruct the breast. This elliptical area is the skin paddle that's been taken from the back to create the breast envelope.
So that's 2 minutes.
Yeah. And sometimes you may come across things like this, where someone has had, which actually looks like a tummy tuck. So you can see an abdominoplasty scar. The tissue from the abdomen has been taken, again, to reconstruct the breast, and she's had an uplift to match this side. So these are the kind of things that you would come across in ladies who may say to you that they've had breast cancer operation, and you would have no idea where the harvest site has been, what kind of operation they've done. So it's always good to be familiar as to what are the different kind of options that are offered to these ladies. With this, I'll end my talk, and I'm happy to take any questions later.
Thank you. Thank you very much, Sadaf. I think just with the interest of time, we'll keep the questions towards the end. So we'll have a Q&A panel at the end. I did ask attendees to post their questions in the chat box, so probably before the second after the second presenter, and you can actually just probably answer the questions. So the questions should be in the chat box for you to have a look at. And I'm sure there'll be more questions coming up. So thank you very much for a wonderful illustration of, the breast lumps, and just to kind of actually give us a clear indication of how to sort of investigate. And I quite like the triple assessment. I think I'll probably use that when I see my patients in my clinic or on the wards, basically. So thank you very much once again. I just want to make sure our second speaker, is she ready? Dr. Sadaf Sarir, are you around? Well, I'll just touch base with Dr. Sarir. I think, yes, she has unmuted herself. Dr. Sarir, Sadaf, do you want to stop sharing the screen, please, if that's possible?
Oh, sorry.
Yeah. That's right, Dr. Sarir, you are actually next. So I'm happy for you to start sharing the screen.
Okay.
Okay. So let me introduce Dr. Sadaf Sarir. Dr. Sadaf Sarir is actually a Dawite 2002 batch, one of my batchmates. In fact, mine, Naseem, and Dr. Ms. Sadaf Jafaboy's batchmate as well. So Dr. Sadaf Sarir is a board certified in general pediatrics and pediatric gastroenterologist, currently working as a peds specialist in the US in Dallas. So Dr. Sadaf Sarir, I fondly remember you as Shehla, so please go ahead, and the podium is all yours. Thank you very much.
Thank you so much, Mansoor, and the team for having me on air today and giving me the opportunity to share my knowledge. I'm a Dr. Sadaf Sarir, as Mansoor mentioned. I do both kind of general pediatric, but my subspecialty is pediatric GI, currently in USA, Texas. So today the topics I chose are mainly going to be focusing on the GI, because 30 to 40% of the cases in primary care are usually the PGI related. I will be touching base with some eczema and asthma at the end of the slides. So let's get started. All right, Mansoor, can you guys see the slides?
Yes, we can. Dr. Sarir, yes, thank you.
Okay. Sorry, I'm just trying to start the slideshow.
So
How do I pause?
you can just click on the slides, and then you've got the show there right at the corner, bottom right-hand side.
Yeah, it's at the top where you see file, home, transitions, animations, and then slideshow. Top left, file, home, draw, design, transition, animation, and then next.
Oh, okay. So I think that's where it was actually.
Yeah. Yeah.
Sorry. Go ahead. All right, from the beginning. All right, there we go. So I got some pictures related internally. All the anatomy is the same. So I'll start with the infants first. So usually in infants, the most common problem you will be hearing from the newborn babies' parents are going to be reflux. So these are some terminology differentiating from a simple physiologic reflux from GERD, regurgitation, and vomiting. Overall, what reflux is—
So that your slides are not moving. So your slides are not moving. Did you click slideshow?
Yeah, but I'm still on the first slide.
Are you still on the first? Okay, you have not moved.
Okay, yeah.
Okay, no problem.
All right, so reflux is going to be a simple reflux into the esophagus without any signs or symptoms. It starts converting into a GERD, which is gastroesophageal reflux disease, when you start having problem with this reflux, like chest pain, heartburn, arching back, feeds refusal in infants. Regurgitation is when the gastric contents are coming into the mouth, and the vomiting is when finally it's being expelled out. So reflux in the babies, the most common cause is, as you can see, this is the diagram of the stomach and the esophagus. There's this angle of His, which means in the babies, this angle is not very acute. And also there's a contributing factor, which is lower esophageal sphincter, which helps in acts like a valve and preventing the reflux. If the baby is laying down, of course, what causes this underdeveloped angle of His? They are laying down, it causes easy reflux of the gastric contents into the esophagus. Lower esophageal
sorry, participants don't see the slides moving. They still see the first slide.
Yeah, we still have the slides as your name, actually. The first slide, which shows your name and your place.
Oh, they are still on the first slide?
Yeah, exactly.
Did you click on the slide show?
Are you able to see now?
Now,
No,
yes.
better, yes.
Yes,
Yeah.
now, yes. Yeah.
You may have to
Okay.
do that manually then, in case.
Okay. Are you able to see this slide, which has a table?
Yes,
Yes,
yes.
we have. Yeah.
Okay, perfect. So I just went over the differences between the reflux, regurgitation, and the vomiting. All right. In this next slide, I was explaining why babies tend to have a physiologic reflux. There is this angle of His between the dome of the stomach and the esophagus. It's kind of, usually it tends to be acute, but in babies, it's not very much developed. So what happens is they lay down, the angle opens up and easy reflux of the gastric contents into the esophagus. Secondly, there is lower esophageal in sphincter, which is not very much developed in the babies. If you lay them, obviously gravity, supine position, all of this works towards promoting reflux, okay? This is physiologic reflux. Other common problems you will be hearing that parents are, how do I know whether this is a simple colic versus GI problem? So technically, it's okay for the babies to cry for 2 hours. Colic is something when you have ruled out other problems as if infection, reflux disease, or they don't have any dirty diaper, other issues. And yet, for no obvious reason, they tend to have a sudden onset of crying most of the times in the evening. At least it happens 3 days in a week, more than 3 hours. It's usually self-resolved by 3 to 4 months, but it can last longer as well. There are no basic tests for it. The difference in these babies are when you, they tend to be easily calmed down by rocking motion, swaddle, or like putting them next to the dryer or some sort of noise, or putting them in a car seat and driving around. So these are the main things where baby is able to calm down versus the other disorders in which it will be constant, recurrent, and baby will seem to be in pain. When to worry about? When you have an infant coming to your clinic with the concerns of reflux or vomiting, what causes for further investigation? If it's not a happy spitter, you look at the growth chart and you notice that slowly over the period of time, the baby growth failure has been coming into picture. They may start plateauing out. The rate at which they should be gaining pounds is not as it used to be. Irritability, fussiness, dysphagia, difficulty in feeding feeds. And that's what happened. The mom will say, I give her feeds. After 1 or 2 hours, the baby starts just pushing the bottle away. That shows that baby cannot talk, right? That they are having problem in swallowing down or is causing some irritation. Arching back, like we call it Sandy Fire posture. So one of the things you may want to know when they are swallowing, are they constantly arching back? However, one common thing is baby do move a little bit around, which is normal. But when they are arching back and they are fussing and crying, that's a sign of reflux hurting them. Blood in vomit or blood in stools, presence of diarrhea, along like watery, loose stools with mucus or blood in the stools, along with vomiting. Fever, of course, it will be an indication of infection. Now, some of these symptoms that I'm mentioning in infants, they can be seen in adults or older kids as well. This is the simple to minimize everything. You can take a picture of the slide. It's really a good one. I kind of made it together. So baby coming to you with the questions of reflux or vomiting, take a thorough history, like how much feeds baby is taking. Are they giving enough gap in between the feeds? Are they burping in between the feeds? Any other sign, red flags that we just discussed are going along with it. If none of this is there, then what you go? Simple physiologic reflux is really no test, you clinically diagnose it. You reassure the parents, because parents, first thing they want to know is my baby growing okay or not? Show them the growth chart, give them reassurance, let them understand the physiology of the reflux. Usually it self-resolves by 6 to 12 months, and then sometime it can go all the way to 18 months. Happy spitter, nothing to worry about. Avoid overfeeding. There should be at least 3 hours gap in between the feeds. If they say, oh, my baby sleeps overnight. So I tell them by 3 months or so, you can let them sleep at least like 5 to 6 hours, but not beyond that, because then, and given the fact that they are growing fine. But at the same time, you want to make sure you're monitoring the caloric intake. If they are overfeeding, decrease the volume. Let's say you have a 1-month-old baby and father is trying to, or mom is trying to feed them like 6 ounces. Of course, baby is going to throw up. So you already tell them that whatever is extra, baby is spitting or vomiting out. So just decrease it by 1 ounce. So maybe from 6 to go down to 5 ounces, not working further, go down by ½ ounce. Every 2 to 3 weeks, they can go up by 15 ml in the formula. You can thicken the formula by using, now there some pediatricians, they use rice cereal. I personally prefer oatmeal cereal because they seem to be more better tolerant of the oatmeal cereal than the rice cereal. You can just roughly have a ½ teaspoon to 1 teaspoon per ounce of the bottle feed. You tell them that they have to shake it well. And also if they have to make sure that the flow of the milk is okay, because you don't want the baby to keep on trying sucking and getting tired. So they can use a little bit toothpick or go up on the nipple size as well. Now, if it's a breastfeeding mom, no worries, just tell them that they can pump the milk and they can also add a cereal to the feeds. Burping in between the feeds, making sure they are prommed up for at least 45 minutes after they are being fed. When they are sleeping, most important, the prophylaxis for the reflux, whether it is the GERD or GER, you want to make sure that when they swaddle the baby, the head end of the bed is raised up and not to lie on a supine position. Because imagine if the baby is throwing up or having a reflux, it can choke on it and you can have ALT episode, acute life-threatening episode. They can have cyanosis and all of that. You always want to have these type of babies who are at risk laying on sideways. But parents should be changing their positions every 3 to 4 hours because you don't want the misshaping of the head skull also. Supine position, of course, after an hour or so, you make sure that they are not laying on their belly or sleeping on their belly, not too much stuffed toys in the crib, SIDS. One more important thing that I want to make sure that all the pediatricians are aware that when most of the parents, they tend to leave the baby in a car seat because it's easy, it's propped up, right? But the car seat, there have been some cases with sudden infant deaths because they can sleep and their airway can collapse on their own and baby can die in their sleep. So it's recommended in USA that do not leave the baby sleeping in a car seat unless it's on the base which goes in the car seat, because the position of the car seat is then much better safe. All right, now this is for the reflux, right? Now you have a baby who, right after you got the physical examination and history, is you start becoming concerned. So what it needs further evaluation. More common during the infancy year, baby in first 6 months of life is usually exposed to milk, right? So if it's a breastfed baby, you want to make sure exclusively breastfed baby that mom has to restrict dairy and soy in her diet. Why dairy? Because cow milk protein allergy is something where baby is not able to easily break it down. So you want to, and it can go easily through the breast milk, and mom has to avoid it for at least 3 to 4 weeks before she would start seeing difference, where the breast milk is going to be free of cow's protein. The reason I mention here soy, because 40 to 60% of the infants, they tend to, in their body, the soy protein tends to mimic like a cow's protein. So it can have the same response. If the baby is on regular standard formula, you want to, and every country has a different names, trade names for these formula. You can try partially hydrolyzed formula. Over here in America, we have Alimentum and Nutramigen. But to be honest, by the time they come to me, I don't even like wasting time because they probably have already failed this. And I just directly go to amino acid based formula, which is completely broken down proteins. It's hypoallergic. And these are some names that I have mentioned. If there is a concerns for blood in the vomit, it can also be from the breast nipple, like skin trauma. You can also, in common protein allergy, do the fecal calprotectin, fecal lukes, or fecal blood just to support your data. And it should improve every 2 months or so once the baby is on hypoallergic formula or mom is restricting diet. You do 2 to 4 weeks trial, usually no medication is needed, symptoms resolved, and yeah, you're good. And they outgrow cow milk protein allergy by 12 months of age in 80 to 90%, but some can continue to have slight symptoms by 18 months. And usually after 12 months, I tend to transition them very slowly, not overnight, completely turning them from hypoallergic formula to a whole milk. No. If they are taking 6 ounces of hypoallergic formula, make it like 1 ounce of whole milk mixed with 5 ounces of formula, okay? And it's okay, you can mix it in the same bottle, it's fine. And you see, initially you can do 1/3 of a ratio, after 2-3 days, half and half, after 4 or 5 days of tolerance, completely transition to the whole milk, okay? If for some reason they are not tolerating it, it's okay. put them back on the ratio, what they are tolerating best with the hypoallergic formula, and re-challenge them after 2 to 3 months, okay? Now, you already tried that, it's been 4 weeks and baby is not turning around. Now the concern comes for further imaging, which can be barium studies, pylorus. If of course there's any anatomical problem, you will have to need pediatric surgeons over there. If you more common in you have a premature X28 weeker or S32 weeker, and you already
have
ruled
5
out with
minutes.
imaging,
5 minutes.
5 minutes. I have not even gone any further. You have ruled out the other problems, and then it can be gastroparesis, slow motility. This is the time where you want to consider in a preemie babies like erythromycin ethyl succinate or bethanechol. Metoclopramide, remember, it has a black box warning, so we tend not to do it unless it's in older kids and it's needed. Medicines, you can try famotidine or you can try omeprazole. Barium studies, as I mentioned, if it's a non-bilious vomiting, you want to consider it's something going on before pylorus. Simply order the upper GI series. It would highlight everything. Make sure with the electrolytes disbalance. Hirschsprung is another one. This is a non-bilious vomiting. You can see the upper GI series with narrowing of the pylorus. This is malnutrition going on. I have mentioned here the doses for erythromycin. You want to start with 5 milligram per kilogram per day, and then you can slowly go up to 10 milligram per kilogram per day. Most of the parents may be worried, why am I doing the antibiotics? You can tell them this dose is way low because it triggers the mortalin receptors in your stomach. And you can continue this for at least 2 to 3 months. Yes, they do not develop any resistance to it. Bethanechol, after if they are not tolerating, then you can add bethanechol to it. After 6 months, if the food allergies are happening, food allergies could be another reason if baby starts having symptoms after 6 months. These are the most common foods which seems to be involved in this. Fever, infection, lethargy, dehydration, jaundice, you do want to consider PGI for metabolic disorders. In adults, vomiting, you can be seen in food allergies triggered. We call it, it's like the asthma of your food pipe, right? Food allergies triggering the response. In these cases, definitely you want to have the upper endoscopy done and see a PGI. The steakhouse or the symptoms you want to consider in your kids, if they say that they feel like they're eating, but it feels like it's getting stuck in the food pipe, they have to drink a lot of liquid, do send them to the PGI referral just to make sure, because you can always do the food allergy test. Mansoor, I'm going to jump directly to the tests which were very important to be considered.
So that we're going to just use our executive powers so you can actually have another 5 to 6 minutes. No problem.
Thank you.
Okay,
so I'm going to go to the most important one, where what you should be doing when you have a kid with abdominal pain or problems. So let's go directly to the test. Okay. So, and I know, as I said, where is it? What test? Okay, perfect. So this is a very, are you able to see this screen?
Yes, we can. If you just enlarge it a little bit, thank you.
Was test. Okay, so you can see this screen. So these labs, CBC, chemistry, GGT is going to help you with overall basic one. Inflammatory markers for sure, thyroid screen, TSH and free T4, lipase and amylase. This is pretty much, to be honest, for even besides GI, it will encompass. Most important thing you want to mention, if someone is coming to you saying that whenever I eat something containing wheat, rye, barley, there could be concerns for celiac disease, sensitivity to gluten in the diet. Most common people do only TTG, IgA antibodies along with IgA levels. If it's less than 3, remember, it's not always going to be positive in these tests. You do want to add deamidated antibodies as well. IgA is more specific for celiac. Certain pediatricians, they tend to start them on gluten-free diet. Please do not do that, because that's where the GI is not going to be helpful, because it can falsely make the biopsy results negative. So let them be on a complete gluten diet and just simply send them to GI specialist. If you do this initial workup, it pretty much, and one more thing I want to add here is do the food allergy panel also. We can take a screenshot of this, so it will really help you guys. Another Stool test. Of course, for infection, you want to make sure fecal blood, fecal calprotectin can really help you indirectly already ahead of time, and you can sometimes use it to make the referral urgent for the GI if it's high inflammatory marker, because you can see in thousands in inflammatory bowel disease. Stool H. pylori, whenever you are concerned for H. pylori, is more concerning than the stool H. pylori antigen than the blood test or the breath test in pediatrics. You can get, if the patient is already on antacids, especially PPIs like omeprazole, lansoprazole, remember, they can have false negative tests, FYI. Other tests, if you delayed meconium passage, consider sweat test, pancreatic insufficiency, greasy stool, test fecal pancreatic elastase. Toddlers diarrhea, very common. They drink a lot of juices, and now mom is concerning for 2 to 3 times regular stools daily, but the child is growing normal, no any abdominal pain or anything. Simply cut down on the juices, okay? Carbohydrate malabsorption, you can do stool reducing substance and pH just to help the support data, but usually it is clinical. I'm going to share a slide for H. pylori therapy also. This is a very good slide. Usually you can do a combination of omeprazole if empirically and the patient is positive for H. pylori. You can do empiric therapy, but again, I don't know how in UK it goes, because usually over here in USA we tend to have adult GI. We tend to do the endoscopy for confirmation. But if there's a delay in referral and it's a very strong positive test, in pediatric, it's less common to have cancer related to H. pylori, to have ulcers related to H. pylori. They can present with bloating, reflux, and abdominal pain. So you can just go ahead and treat them with this. It's a combination of 3 medicines: metronidazole, amoxicillin, and PPI. Someone allergic to amoxicillin, you can do clarithromycin. There is a high rate of antibiotic resistance with clarithromycin, however. One more important thing, whenever you are giving any child for clarithromycin or metronidazole, make sure they take it with food, because it is going to make them a little bit nauseated and sick to stomach. And sometimes giving heads up to the parents really helps with the compliance in these cases. Eczema. We all know, so I'm going to cut to the chase. So whenever you're treating eczema, what I have found, dairy products makes a big difference, and especially dairy, cow milk. In constipation, make sure the toddler is not taking cow's milk more than 16 ounces per day. All right, you can further cut it down, or you can change it to the almond milk or rice milk. Whenever you are prescribing medicine for eczema, I like to add antibiotics along with it, and especially because it helps in a faster healing besides the steroid. Steroid cream on the face, always make sure it's a less stronger one, because it can cause hypopigmentation of the skin. In infancy, babies sometimes just coming with bad eczema, if you put them on hypoallergic formula, remember dairy triggers it, it will start getting better also. Asthma, red flags. Wheezing is not always a reason for asthma. You can have a child, especially the ones who have history of food allergies or eczema, they're more at risk of developing asthma also. So, or cow milk protein allergy. Cough variant, baby or kid is just at night coughing on and off here and there without any obvious symptoms, or when they start coughing after playing, always consider giving a trial of albuterol. I like NABs much better because it can go into more deeper places in pediatric compared to inhaler in much younger kids. So just a food for thought. 2 puffs before physical exertion and then 20 minutes into physical exertion. Have them follow up. They start turning around. You already know this is where the child is already on its way to developing. So so this is asthma, eczema, abdominal migraine. You have a child who is coming in with otherwise completely growing fine, just episodes of vomiting multiple times in a day. And then it goes into weeks of completely being fine. Vomiting along with headaches, this is, we call it cyclic vomiting syndrome or abdominal migraine. It's a very good drug, ciprofloxacin. You can start in a very young kid, 2 milligrams, and you can go up to 4 milligrams every night. And it also helps with cyclic vomiting, and it also helps with appetite. So sometimes I use it to boost up the appetite. And I know what I have heard, ciprofloxacin is over the counter over there, but be sure of this dose. You want to do that. However, if there is a history of any cardiac abnormality, you may want to make sure that you get the EKG, because it can alter the QT interval. If it's more than 10 years old kid with abdominal migraine, you can start amitriptyline at 10 milligram QHS. These two medicines, usually it takes about 4 to 5 weeks to start seeing the difference. So give heads up to the parents, nothing is going to happen overnight. It will take some time. Slowly it will get better. In functional abdominal pain, fecal calprotectin tests and labs are usually normal. Mansoor, are we good?
Yeah, we are good actually. Have you got any other important slide that you want?
I have a lot.
We've got a couple of minutes, and then we'll probably call it in, and then we can ask the Q&A.
Okay.
Yeah.
Here's another slide. What I want you to do is with the clean out. Bad constipation, fecal infection kid is just not getting better. So I am sharing the method I use for my clean out. You do the x-ray, and to be honest, x-ray is not always the reason to diagnose it. Clinically, bad constipation can be diagnosed by the history. It is a 2-day clean out. You can do in 3 to 8 years of age or older one, you can do it. Usually I try, Miralax is polyethylene glycol. Mansoor, do they carry Miralax over there or something like polyethylene glycol over there?
Yeah, they do actually, yes.
Okay, perfect. All right. I know everything is available everywhere. So you can mix 1 cup in 6 to 8 ounce liquid, make them drink every 30 to 40 minutes, total of 6 glasses. If it's a little bit older kids, it's okay to make it 8 glasses. If they don't want to do all this thing, and it can be any juice, clear juice, literally, you don't have to make it like very difficult because you want their cooperation. On day 1, whatever you are doing 6 to 8 glasses, repeat the same thing on day 2. Now, Miralax is slow acting. It is safe. You may start seeing lots of diarrhea by next day. Your goal should be yellow liquidy poop. If they don't want to take 6 to 8 glasses, it's fine. Magnesium citrate is another over the counter over here. The goal you want to be sure about the doses is 1 ounce per age, but its maximum dose is 10 ounces. So if it's a 5-year-old kid, you give them 5 ounces. So it's much easier and tolerating. Lime and berry are better flavor. Whatever you are doing on day 1, repeat the same thing on day 2. One important thing I want to add is sometimes having them on a liquid diet really helps, because which can include water, juice, jello, broth. You clean them out. After that, people think that, oh, it's fine, they're clean out, no need to do it anymore, it's a stool softener. No, that's where you want to make sure you maintain them on some sort of fiber. Fiber gummies have always failed over here. I like to put them either on Miralax, you can do Metamucil, you can do organic fibers, whichever your parent is comfortable with. But they do need to be on this fiber therapy every day. It does not hurt them. There is no complications down the road. Now, people think that just by doing the fiber, it should fix everything. No, it has to be a combined effort. There has to be toilet instructions. Appropriate positioning. Make sure the patient having a stepper under the under the feet when they are trying to use the toilet. 15 minutes after you finish everything, we have something we call the gastrorectal reflex, where the rectum tries to squeeze and get everything out. If the child is playing video game or trying to suppress reflexes at that time, inside what happens, the rectum starts accommodating and enlarging. And that's the time you want to prevent this. Tell them after 15 minutes of finishing meals, whether you like it or not, you feel the urge or not, just go and use the restroom. Dangling legs, that's the same thing I was asking, to make sure you have a stepper, a stool under the feet. Make sure, don't blame the child, just put them on a schedule, have some sort of like a positive reinforcement or like a stickers for the kids. Enema, I'm not a big fan of enema because it may cause the rectal muscles or the anal muscles to depend on it. If you have a newborn baby, it's okay to, and again, this is from the GI part, I'm saying, it's okay to give 3 to 5 ml of apple juice or prune juice with the syringe to them. It really helps them in soothing their stools if they are having hard pebble-like stools. But if hard pebble-like stools with some blood, it can also be indirectly a sign of cow milk protein allergy. Yes, cow milk protein allergy does not always have diarrhea, so keep that in mind. Soy formula, some pediatricians switch them from the regular formula to soy formula. If the kid already has constipation, soy formula is going to make them more constipated. So just be aware of this thing. And
thank you, Sadaf. I think
yeah.
we'll just have to go actually stop here. It's just giving opportunities for question and answer, and I'm sure that So if I may ask Ms. Sadaf Japaboy to kind of actually come on the panel as well. So thank you very much. I think this was a whisk tour of a roller coaster of common pediatric emergencies. I've learned a lot. I'm sure actually my panelists and the attendees as well. Thank you. And the passion was quite visible there. Thank you very much. So let's start with the Q&A. Sadaf, have you read the questions that were posed to you? Do you want me to read them out for you? Or?
Oh, yes, if you can kindly, please.
So I'll start with Sadaf first, if that's all right. Sadaf Fatma Japaboy. Do you want the question, Sadaf, or shall I just mention? So the question.
You go ahead, Mansoor. I think I've read them, but
you've read them. So what is the sensitivity of mammogram in picking up early cancer as a rule-out test?
So the sensitivity varies depending on breast density of the breast. So it varies from anything being 70 to 80% to 90%, or even up to 95%. Like I showed you, the lady who had mammograms where there was nothing visible and the cancer was picked up on the MRI scan, of course, the breast because of the breast density, the sensitivity was low. As compared to the other lady where I showed you a very small cancer, which was not palpable, of course, the sensitivity in that case would have gone up to 95%. What is good about mammograms is the specificity of it. So if you find any abnormality, it is quite specific, and that goes beyond 90%.
Okay, thank you very much. I hope the answer was loud and clear.
Also, there was a question of what age is considered early menarche in late menopause.
Yeah, I was about to come to that, but you've asked the question. Yes, thank you. Which age?
So the onset of periods before the age of 12 or 13 is considered to be early menarche. The natural age of menopause is around 54 to 55. So this is anything beyond 55 is late menopause.
Okay, thank you very much. I think I've just got a question, Sadaf, for you. This is from one of the attendees. Breast specialty, could it all be done as an outpatient apart from the surgical bit, which is an inpatient? I think the question was like, is it mainly an outpatient specialty rather than inpatient apart from the surgical intervention?
Yes, so the cases I showed you with simple round block mammoplasty where the scar was around the areola, we tend to do it as a day case procedure. The one that I showed you where the scar extended from the inframammary fold towards the posterior lateral aspect, that is again a day case procedure. Implants, sometimes we do tend to do them as a day case procedure, but not all the time. For flaps, that requires an inpatient stay. So majority of the cases that we do is actually day case or a 23-hour stay.
So thank you very much. So we move on to Dr. Sadaf Shelasari. So the question for you was, when to suspect a dairy allergy? Do these infants always vomit after ingesting milk?
Sorry, the question is, do these infants
always vomit after ingesting milk?
No, that's a very good question. Not the dairy allergy. Again, it varies. In the infancy year, it's more common. Not every baby will have it, but the symptoms can vary. They can just be very fuzzy. They can have watery stools. They can have mucosal blood in the stools. They can have vomiting, or they can be having a little bit of spit up, but being very fuzzy. Eventually, if this thing prolongs, let's say, and it can start anywhere from within a week of birth to second or third month. So always, it's not always going to be black and white. It can spark, because as the damage or irritation in the GI tract continues, more and more it happens, the baby becomes more and more symptomatic. So you can see the age difference on that. But once you start the hypoallergic formula, I give them, that's why it's a slow response to them. One doesn't work, try the other different type of hypoallergic formula. If down the road, the vomiting may continue, but the symptoms of pain or the baby happy spitter, baby starts becoming more of a happy spitter, and as the time goes, it starts getting better. If vomiting doesn't stop, but the weight gain is there, and the baby is asymptomatic, I don't have to worry about it. If weight gain starts getting concerned for me, This is where sometimes it's more of a clinical diagnosis. You want to either do the omeprazole or the antacid, because remember, with the antacid and omeprazole, it is not going to decrease the frequency of the vomiting. It will prevent the damage to the from the reflux. In those cases, when I have a healthy growing child with just too much of vomiting, and I have tried the other maneuvers which I have told you, then I start, even though it's not a premature baby, I sometimes use the EES, erythromycin ethyl succinate, just to help with the motility for a month or two. So
thank you very much. That's a very, very detailed answer. Thank you. Another question was fecal calprotectin. Is it suggestive of inflammatory bowel disease? Fecal calprotectin.
Very, very highly suggested. So, and the reason why whenever I do these stool tests, of course, when it's infection, it is going to be positive, right? The question comes when there is no obvious infection, and always don't only send the cultures, because if it's a very bad diarrhea, it will be obvious. Sometimes over-infect parasite, they can be nasty bugs where it's on and off. Like I tell them roller coaster, good day, bad day, cramps, abdominal pain, and they can have normal to mucousy stools on and off. So it's always better. Send the cultures. You're already making them do the stool test, then why not do all of it? Cultures, C. diff, ova, and parasite. Cultures are negative. All of these tests are negative, but the fecal calprotectin is usually it less than 50 is good, 50 to 120 is okay, more than 120. In 100 is not worrisome, but if it would be inflammatory, it's going to be very high. Now, if you have the culture positive, fecal calprotectin is going to be positive, which is fine because it's understood the inflammation is going on.
So I think
the infection,
the question was how much fecal calprotectin is suggestive of inflammatory bowel disease. I mean, is it just, if it's just present, it means it's inflammation, or is there like a cutoff in terms of value?
No, there's no 100% cutoff. It is like it can go in thousands. I have seen so less than 120 is okay.
Okay.
But so the difference you can see with inflammatory bowel disease, you can see them in 1200, 900, or 1800, like that, or 2000, 3000. You can literally see that. If someone with functional abdominal pain or food allergies, you tend to see it, but not like more than 500, 300, 400 maybe. So something, it really changes full dynamics. In infection, depending on the type of infection, it can have a very well, but then you are going to have a positive result for some bug also.
Got it.
Thank you. So there's no cutoff as such, actually, no.
No, but usually you would see it if just anything in 1000 should just, and no bacteria on the culture make you automatically jump into, this is probably we are dealing with IBD.
So Sadaf, just a thought, you mentioned that in food allergies, it is going to be normal. So an allergy.
No, not normal, not always normal, not always normal. And I remember, it depends on, let's say you have, the food allergy is also, and we can discuss in future in detail, the food allergies goes as a spectrum. You can be mildly allergic, your body can respond mildly, or it can respond to significant amount. It's all about how your body responds. Everyone is different, and the amount of the triggering food exposed to the gut lining, right? If I'm mildly allergic to cow's milk, but I drink it here and there, nothing is going to happen to me, or my stool test would be normal. But if I'm drinking it every day, and then on top of it, I have mild food allergy to wheat also, but I'm like, it's mild, I don't have to worry about it. I'm drinking wheat bread, I'm eating wheat bread with a cup of milk every day, or maybe twice a day. Eventually it will start showing me, causing me the symptoms. In those cases, when you do the food allergens, usually it's not very high and it can be normal. I would say maybe in 200 or 300. As you start avoiding those foods, you can always repeat the fecal calprotectin. I give it at least 6 to 8 weeks to repeat it. It may turn it down. Fecal calprotectins, instead of using in adults or in older kids who have food allergies, I don't use it that much for them, because my main concern is when I'm concerned about the IBD. I use it, this one, also in like the infants when I have cow milk protein allergy, and now the baby is on formula for at least 3 weeks and it's just not turning around. That's where sometimes I want to make sure that it's getting better, because you may have one number, but then you do want to repeat it over next 6 weeks or 4 weeks to see the trend. It's like one of the inflammatory marker where one number does not help, you want to see the trend. especially also remember in breastfed babies, it's very important where mom is saying, "Ma, doctor, I'm avoiding everything and you don't know." It's because soy is a difficult one to avoid, but not everybody can avoid it. But even food contamination or some inflammation is ongoing. I recently had a child where mom, and I trusted that mom, she was 100% dairy free. Baby continued to have a high fecal calprotectin, and actually it was so high. This was one case in all of these my years of experience where it went up to 900 or 1000. And I was concerned maybe this could be early onset Crohn's disease or ulcerative colitis. Once I put him completely, I convinced mom, because it is, you will have a struggle sometimes with some parent who want to do breastfeeding, but you have to be a little bit more explain them that what is the damage they are doing to their child, and they can meanwhile keep pumping, store that in the fridge after 12 months, or store it in the freezer. After 12 months they can use their breast milk when the baby has outgrown it. So it gives them a little bit satisfaction that I want to breastfeed my baby and I'm not losing it, right? Meanwhile, use this window to put them on the hypoallergic formula. The fecal calprotectin goes down, baby does fine, great. Mom still wants to continue the breastfeeding or pushing you, it's fine. After 6 weeks, when the baby is completely asymptomatic, challenge them again, while mom is still avoiding the soy or dairy in her diet, because maybe by now her milk is more free of cow's protein. So these are the things you can play around a little bit.
I'm sure you can actually write a textbook on calprotectin. Honestly, I can feel.
I can earn very much.
To be honest, I have to actually literally, there was a few more questions, but we've got to end it here, just in the interest of the time. So thank you very much, Sahir. Thank you, Mr. Jafar Boy. You're a pro. You've been coming here. This is your third time, and really can actually enjoy having you here, and really enjoyed Sahir as well. I think this was a truly global webinar because we had attendees from Syria, Iraq, Jordan, Palestine, and Egypt, and obviously from the UK and UAE. So indeed, actually, almost about 40 attendees so far, and this is all recorded. So thank you very much. I feel like, Sahir, I would like to actually call you back in the future and just to kind of complete your sort of 80-slide presentation or something like that. So it'd be really nice to kind of have you back, just like Jafar Boy as well. So I would actually just pass on the sort of the form to Mike, to Naseem, please, to kind of actually ensure that you announce the presentation for March as well. And it'll be great for the panelists to join us in March. Thank you. Naseem, over to you.
Yeah, so guys, in March, we have President of Royal College of Physicians, immediate past president, who is coming on the 20th of March, Professor Derek Bell, to talk about acute medicine as a career specialty in the UK. It's not every day that you get to hear from Derek Bell, so please do attend. And then we have another excellent presentation from Stephen Gulliford, who is a consultant acute physician in Wigan in UK, where I was trained. So I know Stephen very well. We actually trained together in acute medicine. So it's on 20th of March, same time, 5 p.m. I would also suggest that you subscribe to our mailing list if you have not done so already. We have more than 700 subscribers already now on our mailing list. This will save you time from, going to Facebook groups and then clicking on links, because you get everything directly to your mailbox. So March, you will get the link and the banner and flyer, everything, either later today or tomorrow. And just one comment wanted to make, just to avoid any confusion. So EGD, the Sadaf mentioned, is OGD. Okay, so EGD, guys, is just OGD. Esophagus is spelled as ESO in America. In UK, we start with O, or esophagus. So if you saw EGD in a slide, it's just OGD.
I've also said EKG, so ECG.
Yeah.
And also pediatric is spelling, so trust me, they spell it differently here.
That's right. So pediatric is PAEDI in the UK, and it's PEDI in USA. So yeah. So thank you, everyone. We'll see you next month. And thank you to our program coordinator, Dr. Ali, and all the speakers. And we'll see you next month. Thank you.
Thank you, everyone.
Thank you. Bye-bye now.
Thank you.
Bye-bye. Bye.
Bye-bye.